opportunity to be here. It's a real honor to present to this group today to share about my interests and the work that I've done and the work that we understand is so important for the health of older adults, particularly during these times. So I have no disclosures. And so my objective today is to share a little bit about who I am and then accomplish the task of thinking about the intersection between connecting, aging, and our current crisis. So I'll jump right in. And I have kind of categorized this as relationship before task, because I think it's important to understand my relationship to this work before I jump into the topic at hand. So I'll first say, like I included this picture of a book. I have little ones, and stories are often things that ground me and things that remind me of why I'm doing the work that I'm doing. And so a few years ago, after a talk that I attended, I went up and asked the speaker a few different questions. But one of the questions I asked if she had any ideas for children's books. And so she shared this book called Little Mouse's Painting. Little Mouse's Painting is a story about a mouse who shares their paintings to their friends. And each of the mouse's friends shares that like different ideas about the painting. And no one really listens to the mouse, what the mouse has to say. And so this story at its core is about surprises and friendships and the joy of creativity. It also offers interesting insights into and the beauty of varying perspectives.
Cudjoe, sorry to jump in. We're still only seeing the slide title objective under your the slide you're sharing.
You don't see the experiences in training.
Mm-mm. We saw the objective slide that has a relationship task text.
Okay, I'm not sure. Let me stop sharing. I'm so sorry. What about now?
Now we see experience and training. Yep.
Okay.
But we're seeing we're seeing the it's yep, there we go. Perfect. Yep, now we see it.
Okay. Are you with me?
Yep, now we see experiences and training.
Grandparents. Yes. Okay. All right. I'm so sorry. So I would say that because this is my first time giving a talk to this audience, I'll share a little bit more about who I am. And so I would say that the work that I'm doing is informed by my grandparents and also by experiences that I had during my master's in public health. My training there, I would say, really inspired me to pursue work around the health of older adults, primarily inspired by an economist's talk that I listened to during my master's of public health work. This went on to give me the opportunities to participate in the Culture of Health Leadership Program, which I think enabled me to further not only advance myself in terms of understanding about the interplay between the community, but also figure out how to effectively disseminate and engage with community partners. And then my geriatrics training here at Johns Hopkins. I did 1 year of clinical work and then 2 years of research at the Center on Aging and Health. And so moving right into, after joining faculty, I continued clinical care through the Johns Hopkins Home-Based Medicine Program. And it was there that I met Miss B. Miss B is a religious woman who was unable to attend church when I was seeing her. She lived alone in a senior housing development in East Baltimore and had minimal contact with others. She had mental and physical health issues that often led to her having frequent hospitalization. And I would say that she really enjoyed our home visits together. And it was clear to me that she was challenged not only by her mental and physical health issues, but also by other problems. And so as I left her home that day after our visit, I began thinking about the challenges that Miss B faced. And so I was having these in-the-car thoughts, and I would say that I came to the conclusion that Miss B is socially isolated and that this is having an impact on her And so Miss B, I would say, exists in her life on this spectrum of social connection. And older adults aren't all, of course, isolated and lonely. And so some of them are actually integrated. And I have this picture here of the Carters. The Carters are a couple who I met when I was in residency, and they lived in the apartment building that I lived in Washington, D.C. And Mr. Carter had Alzheimer's, but Mr. Carter was active in the community, and she always brought her husband with her to everything. And so I would say that Miss Carter and Mr. Carter are socially integrated because of the activities that they're involved in, because they are engaged in the community that we lived in. And so all older adults aren't the same, and they exist on the spectrum of social connections. And it's important that we understand, where older adults are, because their social connections impact their health and well-being. And my future slides will go more into that. So I mentioned social isolation a few times. And so what is social isolation? So it's the objective lack of or limited social contact with others. And a research tool or even screening tool that some clinical practices are using is the Lubben social network scale, which looks at family and also friendship connections and evaluates whether one is isolated or not. There's another concept that I mentioned as well, and it's important to define it as well, and that's loneliness. So loneliness is the perception of social isolation or the subjective feeling of being lonely. And one way in which we can measure this is the UCLA scale. And so the UCLA loneliness scale in this version has 3 items which inquire about companionship, feeling left out, or feeling isolated from others. And so I think it's important to note during this time that loneliness is an important cue for us to get to attain connections. And so a recent study that was done actually this year amid the pandemic or prior to the pandemic, it was published. And the study basically subjected 15 volunteers to a period of isolation where they were closed in a room and all they had access to was a computer. And amid the study, they did functional MRIs and basically showed the areas of their brain that essentially cued that there was a desire for more connection. And so this further supports that loneliness is a biological cue that's similar to hunger or thirst. And it's this desire for connection that we can identify how loneliness impacts individuals. So this distinction that I want to draw between loneliness and isolation is that loneliness is subjective, whereas social isolation is objective. It's essentially isolation is having low levels of contact, whereas loneliness is this mismatch between our actual and desired relationships. Individuals may be isolated, but they may prefer this, and it's not necessarily unpleasant, whereas loneliness can be emotionally distressing and unpleasant. And so how many people are socially isolated? So we know that about 1 in 4 older adults are socially isolated, and that individuals who are at risk for social isolation tend to be single or unmarried, divorced, or being a widow or widower. Oftentimes they are male, having low education and low income are also risk states for these groups. And so, but we know that from the broader literature that many other groups are at risk for being isolated. And so older adults, individuals who are disabled, I mentioned low income already, individuals who live alone, immigrant communities, the LGBTQ community, individuals with functional and sensory deficits, and also individuals with language differences. Other factors that we think about in terms of considering risk or protection for protection against social isolation include physical health factors, psychological or psychiatric and cognitive factors, social and cultural factors, and environmental factors. And so I'll go through a few of these in more detail. So for physical factors, we know the health and well-being can directly impact whether people engage and are in contact with others. And so chronic disease, geriatric syndromes, sensory impairment is noted. Additionally, psychological and psychiatric and cognitive factors, including anxiety and depression, cognitive impairment and dementia, as well as personality factors. Some individuals, as noted previously, may prefer to be isolated from others. However, it's important to note that though that preference exists, there may be pros or cons of that in terms of its impact on people's health. Environmental factors. And so transportation, walkability of communities, particular housing types, geographic location, and internet access. One of the common things that we've noted over time is that with geographic migration, people may be in less contact with their family and friends as they were in prior times when geographic migration wasn't as high in our country. Social and cultural factors also are important for risk and also protection. So individuals' social support networks, their family, having a family or the lack thereof has an impact. The quality and character of individuals' friends, neighbors, and caregiver, as well as disruptive life events, including grief, retirement, and COVID. And also social and religious organizations. So we've known that religiosity has changed with periods of times. Also engagement of cultural groups and social organizations has greatly changed with time in our country and throughout the world. So back to, I mentioned earlier on the role of children's stories. And so I'll include some of this here. These are Mo Willems' characters, Elephant and Piggy, or Elephant and Gerald, if I get their names right. So here Elephant is saying, Piggy, this social isolation thing is pretty interesting. And Gerald is saying, yes, I know. Is this a new phenomenon? And so this is hearkening back to the history of this issue and going back to the 1800s. Emile Durkheim, a French philosopher who essentially founded the field of sociology, had a few major works, but one of note in its connection to this work is his work, Le Suicide. And so this work is critically important because not only did he focus on the role of social integration and cohesion and its influence on mortality, in this instance being suicide, but this work essentially challenges us to understand how social facts, material and non-material, lead to people living or dying. And the specific health factor here, or health outcome here, is suicide. And so I would say that this directly links to more recent work with the deaths of despair that Ann Case and Angus Deaton talk about when we're thinking about the non-Hispanic white community in our country, where we've seen levels of death go up over the decades. And so this also, I would say, in terms of thinking about deaths of despair, as Elephant and Piggy would talk about, it reminds us of the young English poet, John Donne, who shared these words that maybe many of you recollect from your English lit days, reflecting upon that no man is an island, attire of itself, but going on to say that, and to imply that we are all connected and related in some sense to one another. And so these examples are to show that this is not a new science, but these are things that are important for our well-being and health. Being connected is meaningfully important and has been shown throughout time. So why this matters for health and research and public health. And this quote, I think, from James House in Science in 1988, I think said it best. Social relationships or the relative lack thereof constitute a major risk factor for health, rivaling the effect of well-established health risk factors, such as cigarette smoking, blood pressure, blood lipids, obesity, and physical activity. And so how do we know this? How can we say this? And so I'll just include and briefly mention this work that went along with James House's early work, which basically showed in this graphic you see along the y-axis age-adjusted mortality, and on the x-axis social integration. And you can see these are various studies in different countries that basically show as we increase our levels of social integration, the levels of mortality are lower. More recently, there was a meta-analysis that was published in 2010 that included 148 studies from individuals from around the world. And this study essentially showed that having social connection increased survival by 50%. And so another study by the same author repeated this meta-analysis in 2015 and included 70 studies with 3.4 million participants throughout the world, and basically looked at the increased likelihood for death associated with these factors related to social connection. And so we see that being lonely increased the risk for death by 26%, isolation 29%, and living alone 32%. In a more recent analysis, I'll explain this graphic in more detail by basically showing that on the x-axis, this is our natural logs. And as the larger bars basically indicate the impact on reducing mortality. And so we see at the top and throughout, the yellow bars are essentially different measures of social connection and its impact on reducing mortality. And we juxtapose that to other risk factors or cessation of other risk factors, including smoking, alcohol consumption, and even taking the flu vaccine, physical activity, interventions that address obesity or think about pollution. And we see that social connection and considering all of these things have a pretty significant impact on mortality risk. So the conclusions that we can draw from the data that looks at social connections and its impact on mortality is that social connections has a pretty robust effect relative to other important risk factors. And that these findings are pretty consistent across gender, health status, cause of death, and country of origin. In addition, both objective and subjective indicators of social connection can predict risk. And so from my own work, we found that individuals who are socially isolated or who are low income have higher risk for social isolation, as well as individuals in a particular study where we looked at hospitalization outcomes and death associated with heart failure, that the levels were higher amongst individuals who were socially isolated, and that there's been lower levels of advanced care planning and also higher risk for becoming homebound over time for individuals who are socially isolated. We also know that individuals who are socially isolated have a higher, are more likely to be depressed, are more likely to develop cognitive impairment over time. In addition, analysis have shown that social isolation also increases annual Medicare expenditure by an additional 6.7 billion each year. And so how does, we've talked about mortality and how social isolation is associated with this, but how does this actually work? And so in this graphic, we see that social isolation or disconnection as it's characterized here can influence these important health outcomes through behavioral pathways, biological pathways, or psychological pathways. So coming back to Ms. B and thinking more about our current context. So Ms. B and many others have become socially isolated largely due to the lockdowns that have occurred, increased transportation challenges due to concerns about accessing those things during these times, senior center closures, intention to follow public health guidelines, and anxiety about going out, as well as issues connecting with friends and families due to concern about risk and exposure. And so I'll come back to this. I've come back to this this concept of loneliness because I think in thinking about this parallel with thirst and our desire to connect with one another being a natural instinct. And I think during these times of our pandemic, this desire to connect is challenged because like we see here in this glass of clear waters, I would say during normal times, whereas we might juxtapose our current pandemic to this cup of unpure water where connecting might put us or others at risk. And so I would say that we live in a changing world, one in which we've all navigated the challenges of the pandemic. And noting our time course here in the state of Maryland when we underwent a mandated stay-at-home order. And then thereafter, thinking about the timeline of closures, and particularly noting on March 13th, where senior centers activities closed, which is, I mention this particularly because it's a lifeline and a source of great social connection to many older adults. So before schools even closed, our senior centers closed. And we also know the increased burden that the coronavirus pandemic has had on older adults. The CDC data noting that about 8 in 10 individuals over 65 account for the deaths associated with the coronavirus. And then thinking about juxtaposing what some people have called a double pandemic in terms of coronavirus and also acknowledgement of historical disparities and inequity that exists, we see the impact particularly on the African-American community with higher cases, hospitalizations, and deaths than many other groups, as well as the impact on our Hispanic community as well. So in considering our pandemic, we've noted that we've had to adjust and connect in many different ways. And many have paralleled the pandemic to this challenge of we're all in this same boat, and that's enabled people to think about how they are meaningfully connected and connecting with one another. And I would say that that metaphor is flawed because the reality is that we all are in different boats. We all are coming from different vantage points of privilege. And a more appropriate parallel is that we are all challenged by the same storm, and that in coming together, I think we can figure out challenges to address this. So I would say that the tools that we can use to address social isolation historically have been through in-person connection. And I think there's are some bright spots regarding addressing social isolation prior to the pandemic. But I think we all know that we've had to adjust how we can support one another through virtual means or through means of connecting at a distance. And so going back to what we can do and how we can actually address this, I think we first have to think about primary preventative strategies in terms of thinking about how we identify individuals at risk, and then secondary preventative strategies and thinking about how we can decrease the consequences of people who are already experiencing loneliness and isolation. So the challenges amid our current pandemic to summarize, have been a transformation in how we interact. I think we all had initial hopes of the restrictions being temporary, but we've seen a persistence of these challenges over many months. We've also seen, and data is increasingly coming out about the worsening of isolation and loneliness amid the pandemic. We also know that many people's source of connection is their social or religious supports. And so that these gatherings have definitely been impacted during this time, as well as how people interact with others who are in healthcare settings like nursing home or hospitals, or even how older adults who live in senior congregate settings interact with one another. We've also seen older adults impacted by forced retirements, whereas employment is also oftentimes a source of connection. But during these times, we've seen furloughs and layoffs that have impacted all individuals, but in higher instances, many older adults. And so we also note that how people are engaging in funerals or in grieving the loss of loved ones are particularly impacted and occurring in a different way. And we aren't even beginning to understand the residual impacts of all these experiences on our social connections and the future of our social connections going forward. We also, amid the challenges that we've noted with the pandemic, this field of study also is challenged by a few different things, which I'll point out briefly. And that's the conflation of social isolation and loneliness with other related concepts. There's been a great attention to the deficits that exist or the absence of connection or the experiences of loneliness, and not much attention to where are the assets and how can we leverage those assets to develop solutions for those who are experiencing the isolation and loneliness. You've probably experienced this here in my own talk, but there's variability in terminology. Going along with that, there's variability in terms of measures and outcomes. So there's great opportunities here to think about how do we align these things to make the research clear and develop solutions in a more efficient way. Also, there's limited research on at-risk groups, particularly individuals who are in low-income settings. And the quality of the intervention literature is also challenged. And we haven't even begun to really understand the role of technology and how it can impact social connections. So I would say the opportunities that we have here are that amid our current pandemic, many individuals are experiencing isolation. And so there's greater awareness about its impact on our lives and on our health. We've also should acknowledge the opportunity that exists as communities have come together to help one another, as well as there's been increased alignment of resources in communities to support the care, as well as to come together to advance research in science of social connection. We've also noted the opportunities of how technology has been rolled out in health systems and healthcare settings, as well as in people's own home to advance telemedicine, as well as virtual interactions with loved ones. And also, more time and attention has been paid to our social connections. And so I would say we're fortunate to have the National Academy's recent report, which included important elements about the role of developing a more robust evidence base, the role of translating what we currently know into healthcare practice. Again, calling to improve awareness, as well as strengthening ongoing education and training, and strengthening ties between our healthcare system and community-based networks. And so in conclusion, I'll say that it's critical that we increase awareness about the role of social connections in our health, it's critical that we think about in clinical and also research studies to assess social isolation and loneliness. We also, I think it's critical that we meet people where they are. Some people are isolated, and some people are integrated, and understanding where people are and figuring out how we can support individuals. And then also engaging individuals who are most impacted to devise solutions to support them as they age. So I would acknowledge the older adults in my life, and also my research mentors, and our funding through the NIH. So thank you.
Dr. Cudjoe, thank you so much for that really, really great overview and presentation of these, critical concepts now, especially in the era of COVID. So I'll invite everyone now. I've seen several questions come through on the chat, and I'm going to start with those that I have right in front of me. But if anyone else wants to ask questions, please do go ahead and include them in the chat, or raise your hand if you would like to ask them personally and in person, or virtually. Tom's, one of the first questions comes from Dr. Sklo, and he specifically asks, is a high loneliness score even possible among those who objectively are not socially isolated? Namely, is their mortality as high as those who are both socially isolated and lonely?
I understand him correctly. So the individuals who are connected or who are isolated can, or who are, if they're not isolated, they can still be lonely. So I think the thing that people say is that you can be lonely amid a crowd of people. And so that, I think that it's important that we distinguish the two, because the solutions that we might develop would be different for addressing the different problems. So I don't know if that answers his question, or I need to further clarify.
No, I think you got it, Thomas. And then, Moises, one thing I'll comment briefly too. One of our main rationales for inviting someone like Thomas to speak to us at the Cochlear Center, which obviously focused on hearing, is, I'll say from my personal experiences there, Moises, taking care of patients. One of the reasons why I got interested in loneliness early on is I've seen people who oftentimes have more of a moderate or severe hearing loss, who by virtue of their spouse are still socially integrated. They still are dragged to events all the time. So by an objective scale, it seems like they go all the time. And yet when you talk to them, they feel tremendously isolated though, because they can't interact though. So even though it seems on face value, they have a lot of connections. In fact, I think the richest sometimes may not be there because of the underlying, the lack of the substrate for effective communication sometimes. Dr. Cudjoe, another question now comes from John Swen, who's one of our trainees at the center, I think you know well. And John writes, there's a distinction between structural versus functional factors that may contribute to increasing risks, like built environments versus emotional behavioral health, respectively. Regarding structural factors, then specifically, what are some potential points of interventions, in your opinion, for mitigating social isolation? So the idea again of what structural factors could be addressed to address social isolation and loneliness.
Yeah, so I'm sitting in a structural factor, I would say. I'm sitting at the Paseo de Marti in Havana, Cuba, and I would say social infrastructure is critically important for how people connect. And I think that if you want to read more about this, I would say that Palaces for the People by Eric Kleinenberg is a great read that talks about how we can build social infrastructure to facilitate people connecting with one another. And so I would say that, as well as that, environments that are strained, think about crime-ridden or violent environments where people don't feel safe with connecting with others. That strains the opportunity and ability to connect with one another. And also from some of my own qualitative work, I know, John, you've done work in housing, and some work that we have been doing over the last few months, where we've interviewed housing managers and stakeholders, and we found that in some of those settings, some of the way the environment is set up facilitates or hinders social connection, and some of the I would say social environment that exists in certain settings may strain people in their interaction with one another. One other thing that they particularly point out is bullying that goes on. And so that, that's more of a social factor, but certain structural factors that lead people to be in certain housing types may select for certain individuals who have lived strained lives themselves. That may transmit itself to the environment as well.
Thanks, Thomas. Thomas, may I ask a quick follow-on question on that one, which is always interesting to me. I think a lot of social, a lot of social determinants of health, the solutions sometimes aren't what we can do individually in a clinic setting in a 45-minute appointment, right? There are more broader structural concerns for a lot of social determinants of health that really have to be addressed at the policy political level sometimes. When you personally now, speaking as a geriatrician now, when you encounter someone in your panel, an older adult you routinely see, who is basically lonely by virtue of their situation, their setting, what do you actually offer them? And what can you do essentially in the context of a 45-minute appointment sometimes that you obviously can't address the structural concerns all at once, or if even at all? How do you counsel those patients, like what to do next?
Yes, I think first assessing this, and I think here at Hopkins and our EHR with EPIC, we have the social determinants of health wheel, which social connection is one of the assessments on there. So I think we're assessing this first so we can identify the problem if it exists. And I would say that a thorough social history, I think we are taught it in medical school, but I think we need to revisit doing a thorough social history in terms of understanding people's social resources, their family and friends, and their trajectory, understanding more about their trajectory during the course of their life in terms of their relationships with one another. And so concretely, if individuals have those family members or friends, I would say I encourage them to engage them in the care that we're providing. For Miss B, who I shared, we actually referred her to the PACE program. And the PACE program is, of course, a model of care, but also there's, during non-COVID times, there's a day center in which they have recreational therapy and opportunities to connect with others. So I would say that I think that we should be supporting policy strategies that fund PACE programs that support senior centers and also think about ways that, because most senior centers don't have transportation, but think about ways for older adults being able to get to some of these facilities.
Thanks, Thomas. So, following that question, there's another question in the chat which sort of builds off something you just said, which I think was very astute. It's like I asked just, how would you treat it clinically? Well, the first thing to do is, actually get a good history and to assess it. So the question here comes from Pablo Martinez Amezcua, who's one of our trainees who you'll meet in a little bit too as well. And he writes, great presentation, Thomas. Could you speak about the tools we have to measure isolation and loneliness? How long are the questionnaires? How can we use these measures in analysis? And is there a gold standard? So very much again, the idea of measurement. Maybe and is it, there's a clear research standard for measurement as a clinical, or is it one the same, or should they be, or is there work to do there?
Yeah, so I would say that the loneliness, for loneliness, I think that there's more of an agreed upon gold standard, and that's the UCLA loneliness scale. And it's a 3-item scale that I shared. I may have moved through it too quickly, but I think that can be used in a clinical setting, and there are studies that have used it in the clinical setting. Whereas isolation, I encourage the use of the Lubben social network scale. It's 6 questions. It was developed by a social worker. He developed it for that so that it could be used in a clinical setting, and it's been validated internationally. So, and I think those two tools can be used to measure social isolation and loneliness. And when people ask me, I encourage the use of them. I think push going further. Amid these current times, we can say that can we use those, particularly the Lubben social network scale during the current pandemic? And I would say that it would definitely, more people would test in for being isolated during these current times. So I think we need to reflect upon how do we adapt some of the current questionnaires that we have to our current context. But
thanks. So Thomas, along the same lines, and clinically, then do you routinely use any of these scales, like in clinical practice, like when you're seeing patients or that are tracked longitudinally for patients?
So in the EPIC, the EPIC wheel, that's the Lubben social network scale.
Oh, it is. Gotcha.
Yeah. So
Okay.
if my memory, I'm pretty sure. I have to look again to be side by side, but at least there's 3 questions that are from the Lubben social network scale. Yeah.
Do you just, and building off that maybe one more time, the rationale for the capturing social network versus loneliness, though, like in something like EPIC, is there a reason, given that it seems like what you're suggesting is that loneliness may be a more important determinant than isolation?
I think both of them are important. And I think we should capture both, because individuals who are not connected to other individuals, but who are lonely, who are not lonely, I think still, I think we should be identifying them and addressing the isolation that exists. I think those individuals who are lonely probably are, if evaluated in a clinical setting or other settings, I think you may identify them more easily because they'll tell you that they're lonely. Whereas individuals who are isolated, we may not necessarily be able to detect them as easily because they may not express. I may say that, I'm good, but I spend all my time alone, and I don't benefit from the various great resources that exist from connections with others. And I think those they come in different forms. If we think about our own networks and how access to certain information, access to instrumental support, access to people who might help us buffer our stress during challenging times. We know that our social connections have a value. And so in moving further and thinking about how that, Jonathan mentioned it kind of in terms of thinking about structure and function, and then there's also quality. Quality is oftentimes not talked about. We often interpret connection as all good, but we know that we know about intimate partner violence. We know that relationships can be strained, and so that can negatively impact our connections with one another. And so say all these concepts are both important. Just like we wouldn't say that someone's hypertension is not as important as their diabetes. Both of them are critically important.
Thanks, Dr. Cudjoe. So another question here comes across from Jerry O'Donoghue, who's one of our colleagues and I'll say a friend of mine in the United Kingdom. Good to see you, Jerry. Thanks for joining the call. And Jerry, Dr. O'Donoghue asks specifically, he says, excellent webinar. To what extent do you think broadly sensory impairments, how, I guess particularly hearing loss for our center, obviously, but visual impairment obviously as well, another focus of ours. Broadly, how do you think from a clinical or research perspective, how you think it impacts social isolation and or loneliness?
Yes, you and I both know that it's important. All of us know it's critically important. And Frank, you've done work on it. I've collaborated with you all on thinking about how hearing impairment impacts how people participate in, with one another. And it's critically important that we understand what people's hearing is and thinking about solutions. If we are going into the community and engaging people, if they can't hear us, if we can't support them and that part of who they are, none of the other strategies that we apply can be effective. So, and if they can't engage with one another through the visual impairment, I think that all of our solutions are challenged. So understanding where people are in terms of their sensory abilities is critically important to how we connect with them and how they connect with others.
Thanks, Tom. And then Tom, just be mindful of time. I want to take sort of, I guess, moderator's prerogative, ask one last question and we'll sort of close out there. So one thing I think I might have missed your talk, I'm not sure you talked about specifically was, but one thing I've always been struck by in the past was, John Cacioppo's work looking at loneliness and its isolation in terms of physiologic effects on inflammation. And I honestly, I lost this train of research maybe several years ago. I know he died very early, just a few years ago. Do you, just as a your general take as a geriatrician who studies this field, his work looking at the physiological effects of hearing loss, or not hearing loss, just social isolation, increased inflammation, things like that. Do you see that vein of research? Is that accelerating broadly? Is that being taken up, or is it, I don't want to say die off with him, or is that sort of an orphan area of research now, the physiological effects of isolation?
It hasn't. We actually, I presented at GSA cross-sectional analysis using NHATS data, looking at our construction of social isolation and inflammatory markers, IL-6, and we do see a relationship. And so I would say the reason that biological markers are of interest to me is because many of the studies that have sought to develop interventions to address social isolation and loneliness haven't necessarily borne out a positive impact. And so, I think that, maybe there's other measures that we can use that are value or showing the benefit of these interventions. And it may be a more proximal measure like inflammation. And so this work is, it's a line of research that I'm engaged in. And I think that amid the pandemic, a lot more people are interested in the impact of social isolation and loneliness on health. So I think we'll see more of that. The NIH has released various calls to R01 level funding to study these things. So I think we'll see more and more of it with time.
Great. So again, I want to thank Dr. Cudjoe for really an excellent presentation, giving us sort of a summary of what's out there and things to do remaining in the field. More importantly for the audience, I want to thank all of you for joining us. Thomas, we had over 60 people today join from, actually, from what I can tell, from around the world, actually. So appreciate everyone coming from different time zones. I know it's always hard. This webinar will be recorded like all of ours are. It'll be available on the website. For the trainees, you guys will be meeting with Dr. Cudjoe now in the following hour, and another more of a Zoom webinar, a Zoom regular meeting format. It'll be a little more casual. And again, for all of you interested in our future seminars, please do visit the website at JHU Cochlear Center. You can register there. And in particular, in the next month, everyone, this call and anyone else interested, will be getting email about signing up for the Cochlear Center Research Week, which we're really excited to offer in we think a slightly more virtual format that will be more engaging than being in a meeting for 8 hours in front of your computer. So we're optimistic that will be a good experience for everyone. But Dr. Cudjoe, thank you very much again for presenting to us. Have a wonderful Thanksgiving with your family. And thank you again for joining our trainees in the next session. Take care, everybody.